than if you just have iron deficiency. So if you become anemic and your blood is really low, below 90, you can get into problems with things like heart attacks. If you have any triggers there to have a heart attack, or your risk factors, palpitations, and you get cracks in the mouth, corner of your mouth, and things like that if you're anemic and pretty iron deficient. So there's been a couple of big trials lately looking at are people who are iron deficient but not anemic symptomatic. So they've sent out surveys, and there was 3 years ago an article published in the Canadian Medical Association Journal, so medical Canadian physicians, where they took women who were iron deficient and gave them either iron tablet or a placebo. And in that trial, then they looked at quality of life indicators, fatigue scores and things. So the women who got the iron tablets reported much less fatigue and overall complaints than the women who got the placebo. So we're not saying that iron deficiency is, your body needs iron, but it's much less serious than if you're anemic. So if you're anemic and your blood is really low, you got to see somebody more quickly, and it may need iron IV over something orally. But the jury's really out on whether there's an urgency to treat iron deficiency without anemia. Quickly you need to see specialists, this and that. But I definitely do treat people who are just iron deficient. I say, you gotta get on something to try to increase your iron stores.
But you could take the time then to try different things.
Exactly.
Anemic, you
Yep.
have to have something.
I rarely give people IV iron who are just iron deficient.
Yeah.
I think it's only happened in one case because they said, I can't go on with my life, I need something. And but I really try to get patients to take oral iron because there are risks to IV iron. You can't get iron overloaded, so it's a direct infusion of iron into your blood, so there's no way for your body to get rid of it. So these macrophages eat it up and shove it in your liver and your kidney if it stays around too long. So that's why I caution patients, don't go out and beg for IV iron, really give oral iron a chance. A couple more questions?
If they are on IV iron, should their liver and kidney be checked regularly? The function?
There's no good guidelines for that, but I do check their liver enzymes, and you need to have your kidney function tested as well. I did have a patient this year who got IV iron who a week later their liver enzymes went through the roof, but then came right back down. But again, there's no indication of, or no guidelines to say that we should be checking them regularly. Because really, after a little while, if you are truly iron deficient, and there's some reason for that, after you get IV iron, you should start to build up a requirement again, so it wouldn't be permanent damage. Like the rest of my patients who get blood transfusions, and then the iron, so they're dependent on blood transfusions for hematological problems, and then the iron builds up, and there's nowhere for it to go. And it lands in their heart and their liver and kidneys, and it causes a real problem.
Suggest that Paramax also should be taken on empty stomach?
The iron salts?
Paramax.
Ferromax, they also recommend that you take it on an empty stomach, and that's the one that's sort of more gentle on the stomach. So most of my patients have much less GI complaints about Ferromax. So I do recommend that on an empty stomach as well. But the sort of worry about it's easier, it's a little more expensive, it's only once a day, is it is a polysaccharide, so it's not a pure iron salt. So even though there's more, the bottle says there's more elemental iron, I think it's a little less bioavailable.
And along with vitamin C is okay with it?
Definitely.
And how long one can take?
You can take it, I say you shouldn't take them forever, because again, there is a recommended daily intake of iron. So if you're not iron deficient and you're not anemic, after 6 months or so, I ask the family doctors to follow up and follow up again. So stop it, but then a month later, check the CBC and ferritin to make sure that the iron stores haven't plummeted. Because you can, even though your gut is programmed not to absorb any more than 1 to 2 milligrams of iron a day, you can sort of max that out. So every single day you're at the maximum level of your iron. Your macrophages will start to gobble a bit of that up and store it in your liver.
Are ferritin and iron interchangeable terms?
Not at all.
No.
So the best measure is definitely the ferritin. I don't actually use the iron or the trans saturation unless someone has an acute phase reactant. And even then, I think that all those iron studies, like the iron, the trans saturation, also can be influenced by acute phase reactants. But when we're treating things like hemochromatosis, which is the opposite spectrum of iron deficiency, those measures are a good way to measure the iron coming down. There's been good studies to show that they're not as good of a measure as a ferritin at looking at your iron stores. This ferritin reflects your stores. So this is how much store you have in your body. So it's about 20% of your iron that's not used by your red blood cells is stored as ferritin, whereas pure iron is not. It's just serum iron. I don't know if Dr. Fardys, Dr. Scully agree with that.
I agree with everything.
But I don't order them actually. I just order them ferritin.
Dr. Costello, I have one last question, just before we go off. So iron deficiency is most predominant in women.
Definitely.
And sometimes I guess it's likely caused a menstrual bleeding. So is there a supplement available that has, say, a birth control and an iron supplement in the same pill?
You're looking for a big ticket. No, there's not.
Good marketing tool.
Yeah.
Yeah.
What's your preferred order of trial those different supplements? Like you said, Ferromax first?
I do. I use Ferromax because I think people are going to be more compliant with it. But if someone's anemic and severely iron deficient, I would try ferrous sulfate. But I do find women are definitely more likely than men to have all these GI complaints. So young women, if they're not that anemic, but they're pretty iron deficient, I'll try Ferromax because I think the chance for them to be compliant with ferrous sulfate or ferrous glutamate is more likely that they'll take the Ferromax. And if you have no GI upset and you want the best bang for your buck, again, there's absolutely no randomized control trials. There's no good comparative data at all. But from some pretty people I have high esteem, like Dr. Brendel Adams, who was a hematologist here for over 50 years, he says his drug of choice is ferrous sulfate. And again, a hematologist I work with in Halifax, who is an iron expert, she has the same sort of thought as me. She tries young women with Ferromax, but puts people on ferrous sulfate. I don't know if Dr. Scully and Dr. Fardys have any choice.
I usually use ferrous fumarate actually.
Not put in a word for ferrous glutamate.
Yeah, I don't find many people can tolerate the sulfate.
The sulfate's pretty
The people
hard.
I see usually are quite iron deficient, and I don't find that the Ferromax gets their iron up.
Yeah, exactly.
And the sulfate I find hard to
Very
tolerate.
hard.
So I actually really use very high doses of fumarate. I hope I'm not overloading anybody. But
And fumarate
I
also
alternate
comes in a,
fumarate and gluconate.
like
I give
fumarate
them-
comes in a tablet that can dissolve to like a wafer
Yeah.
that I've seen.
And there's also a liquid, but it's black and it can stain your teeth. So you
Yeah.
can brush your teeth afterwards. The liquid palaver.
Yes, that's right. That's
Yeah.
what we use in children.
Yeah, and some
And
adults
some of the
prefer
children,
it.
we did see that their teeth were stained.
Yeah.
Oh,
And I think that herbal product, I think it's got somebody. Yeah, I think it just has.
It's ferrous glutamate and ascorbic acid.
Yeah, yeah.
Yeah, so I like, that's just one that I chose to see what.
Is it
I
Vita
haven't yet gone
something?
back in for my second blood test.
Yeah. So I mean, if it tastes, like, if it tastes
fine.
if it tastes better, then
Yeah, I don't know, I didn't look to see what the levels of it were, but it's.
I think it's 60 because I think somebody brought it into me, but I really am not sure.
I'm meant to take it twice a day or whatever, but
Yeah.
and it tastes, there's no bad taste to it, it doesn't seem to bother my stomach at all.
It didn't stain your teeth either?
Those glutamate
Your teeth are
inhibitors.
not stained with that. It's a liquid.
I don't know, but I don't think so. It's not so much black as it is. It's like deep yellow. Like that's like yellowy browny, and I didn't know that was a side effect. So, but I didn't notice anything.
Well, you just have to
But I also drink coffee, so.
tell people to brush their teeth.
No coffee with
Sorry.
So the fumarate, you think it has a high, is to get your iron up the fastest, would be the best choice?
So these three,
You know, as Dr. Costello says, and the more I'm listening, the more I think we really have to do some trials here. There's a surprising lack of information about this. Like for the, because I've had some patients react to the quicker IV iron, I use Venifer, but I use it twice weekly for 5 doses. So I give 1 gram in 2 weeks that way. So the thing is, there's not a lot of data. The ferrous fumarate, because I'm no good at taking things on time, I start people on I get them to try either, and go 1 week and then 2 weeks and then 3 times a day, and not to worry about what they're eating, because if they or what they're doing, just to try and take 3 times a day and take something for if they have a change in bowel habit, take something for that. So that's what I try. But
for compliance.
But you have to, that's a lot of iron, so I always check like in a month. But I had one gentleman in summer who had been on different things for ages, and he, I said, just try this for a month, and it was the most impressive, because his version went from 8 to 100 in 1 month.
Oh.
Yeah. He'd already had surgery and things so his reason for being iron deficient was dealt with, but he was just feeling miserable, and we were and he'd been trying different things, so I said, well, we'll try this for a month and then decide if you need IV iron. So, but there isn't
There's
great
absolutely
evidence. It's
like I
just-
said, for this master's course, that's what I've been using as my research question for a course, and there's none. There's no randomized data, there's no comparative, no historical controls.
And there's just been an evidence-based thing that for children, there's no evidence. It doesn't mean that it doesn't happen, there's just no evidence that treating iron deficiency makes a difference. And there's no evidence that treating pregnant women, but again, I think there's just not the evidence, because there is a lot of evidence that iron deficiency is associated with higher risks in pregnancy. So it's very complicated.
Any more questions you can save for Dr. Costello at panel discussion? So our next speaker is Dr. John Fardy, and Dr. Fardy is from St. John's. He attended Memorial Medical School and trained in internal medicine at Memorial. And he furthered his training in gastroenterology and clinical epidemiology at the University of Western Ontario. Dr. Fardy returned to Memorial in 1990, and he's currently a professor of medicine and gastroenterology at Memorial, and he's chief of the Division of Gastroenterology at Eastern Health.
Thank you. I'd like to thank Dr. Scully for the opportunity to come and talk to you tonight. I am a little out of my element, I have to admit, because I usually teach young medical students and residents who believe everything I say, or I talk to old doctors who believe nothing that I say. So I'm hoping that you guys might be somewhere in the middle. And what I'm going to do is talk about the investigation of iron deficiency anemia, and I'm going to wander around a bit because I have this fancy device that allows me to do that. So what we're going to do is look at the common causes of iron deficiency anemia, which is going to be IDA in a lot of these slides, just to orientate you, and then describe a management strategy that we would use for people who are found to be iron deficient. So iron deficiency is very common, 2 to 5% in adult men and postmenopausal women in the developed world. But as Dr. Scully and Dr. Costello mentioned, in the undeveloped countries, iron deficiency is absolutely rampant. And I had a beautiful slide from WHO which shows how much iron deficiency there is in other parts of the world, but I don't have it included here because I had to code some of these things to make it fit into 30 minutes. The reason I'm here is because I'm a GI guy, and that iron deficiency is a very common thing for us to see because blood loss from the GI tract is the most common cause in men and postmenopausal women. And we don't really mean postmenopausal women, we mean women who are not having regular menstrual cycles, because menstrual blood loss is the most common cause of iron deficiency in menstruating women. And we actually have two different sort of algorithms for how we deal with iron deficiency, whether or not it's in men and postmenopausal women as opposed to premenopausal women. When a gastroenterologist thinks about iron deficiency anemia, we're afraid that someone has got stomach cancer or colon cancer because these conditions do present with iron deficiency anemia. And those things are really the priority in terms of our investigations to look for a cause for iron deficiency in postmenopausal women and in men. There are also a number of causes of malabsorption, diseases that cause you to not to absorb iron, and celiac disease would be one of the most common ones we see, which is a reaction to gluten and affects the lining of your small bowel so that you don't absorb iron correctly, and you don't absorb a lot of things. Although iron deficiency is probably the most common presentation that we see in terms of celiac disease. Poor dietary intake we talk about, but it's a very uncommon cause for iron deficiency in developed countries by itself. But if you look at adolescent females with heavy periods and poor dietary intake, then those two things add together to potentiate iron deficiency. But by itself, it's an unusual cause in North America. Blood donation is an interesting one. I have a few slides about that because it's only recently, I mean, I'm an old guy now, and when I went to medical school, they didn't teach us that blood donation could cause iron deficiency. But it's kind of a no-brainer if you're coming and giving blood all the time, then your iron should get low. But we never used to ask people about that. And it's only within the past 10 years that at least gastroenterologists have twigged to that, and I have a few slides on that. Surgery on your stomach, because the stomach is important in terms of the acid in the stomach, helps to change the iron into a form where it is more easily absorbed. If you do things to the stomach, then that can lead to iron deficiency. And all of those drugs that you take for your aches and pains, like Motrin and Advil and Aleve, and those kind of things, these non-steroidal anti-inflammatory drugs, they all eat up your stomach. So as a gastroenterologist, I don't like giving people these drugs because they eat up people's stomachs and cause ulcers. And I don't like giving iron supplements because people complain about gut grief related to those as well. This is a slide just to show that the reason that you're going to be iron deficient is going to be perhaps because of malnutrition, not so much in North America, but in other parts of the world. Related to malabsorption, and there are a variety of causes, but celiac disease probably is the one that is the most common. And then there's going to be GI blood loss, either from the upper part of the gut or from the colon here. And generally what we're concerned about in postmenopausal women and in men is that if they don't have a malabsorbing problem, that they may have a source of blood loss in their upper or lower GI tract. And that's generally why gastroenterologists get involved. This is just a slide to show what happens with acid and iron in the stomach. And acid actually helps change the iron into a more absorbable form. And most of the iron is absorbed in your very proximal small bowel up here in the duodenum. So that surgeries that interfere with stomach acid or interfere with where things come into your gut will interfere with your iron absorption. I'll talk a little bit more about that later. This is just a really fancy, colorful slide that I don't understand, but I just put it up. There was a recent review in a journal which I love because it's called Gut. Isn't that a great journal? Yeah. So and it is a really good journal. It's a British journal about iron deficiency anemia. This was some data that they had from the UK. And here we have abnormal uterine bleeding as one of the biggest causes of iron deficiency. Long-term use of aspirin or non-steroidal agents. Everyone is on aspirin now for their heart. And even one aspirin tablet a day can be enough to cause iron deficiency. Colon cancer is there, certainly. Angiodysplasia, which are funny blood vessels. Blood donation came out in this paper, probably one of the first times that I had seen it written down somewhere that blood donation was a cause of iron deficiency. Stomach cancer and peptic ulcer disease, or ulcers in the stomach, also showed up there. But it'd be nice to see some Newfoundland data, and certainly we have some Newfoundland data from a study that we did a few years ago. This is a little bit different because these were patients who were referred to a gastroenterologist, so they'd already gone through a filter from their family doctor. And I think that that's why abnormal uterine bleeding is a little bit lower here at 16% than it was in the UK data, and that's because the women with abnormal uterine bleeding didn't get sent to a gastroenterologist because that was obviously the cause of their iron deficiency. But again, if you look at the other causes, long-term use of non-steroidal agents are similar. Colon cancer is a bit higher, and I think this is related to the high incidence of colon cancer in Newfoundland. And if I could tell you one thing, if you are 50, then you should get a FIT test done. If you don't know what a FIT test is, then Google it and find out how you can get referred to have a FIT test done to get screened for colorectal cancer if you're over 50 years old. Angiodysplasia, again, funny, blood vessels, blood donation, again, turned up in our study. Gastric cancer was fairly low here, and I'm not sure why that is, because we certainly don't have a low incidence of gastric cancer here, but in terms of presentation, gastric cancer tends to more often present with symptoms than it does present with iron deficiency. And this study really was of patients who were referred because they had iron deficiency and not because they had other symptoms, so that might explain that. But otherwise, these numbers were very similar to what we saw in that study from the UK. This is just a reminder about the iron deficiency in blood donors. In that study that we did here, the blood donors who are iron deficient were the people who get called every 56 days to come back because they need their type of blood. Then they go back for 2 or 3 years in a row, and then all of a sudden they say, we can't give any more blood because you're anemic. That's probably not a surprise in that situation. When we think about iron deficiency, we think about occult GI blood loss. And when we think about blood loss from the GI tract, most of the time when we're talking about iron deficiency, it's occult. And that means we can't see it. So you don't have any indication that you're losing sufficient blood on a daily basis to make you iron deficient. It's not, you don't have to have blood coming out the top end or throwing up blood or having blood coming out the bottom end. This blood loss is occult so that you have no idea that it's happening unless you test your stool for blood or someone looks at a hemoglobin. Then malabsorption is another of the causes. Celiac disease is up there. This is a disease where you have a reaction to gluten that causes malabsorption, gastrectomies, and then Helicobacter pylori, which is that bug that's associated with ulcer disease. I have a few slides about that later on. And then there are some other uncommon things. Non-GI blood loss, menstruation is up there along with blood donation, and as Dr. Costello mentioned, hematuria and nosebleeds, when they're very, very bad, can also lead to iron deficiency. This is just some stuff that's been talked about, I think, already, so we don't need to go over that. In terms of who should be investigated, I think if you're anemic and you have iron deficiency, then you need to be investigated, no matter what the level of your anemia. If you're iron deficient without anemia, I have a slide at the end that suggests that maybe it's not as urgent to look at that. But certainly the lower the level of your hemoglobin, the more anemic you are if you're iron deficient, the more urgent it is to have a look and see what's going on, because the more serious disorders tend to be associated with more serious iron deficiency. We talked a little bit about ferritin and how it's a good marker. It's a blood test that we can do. It's a very easy thing to assess iron stores. And it really is the thing that we hang our hats on in terms of sorting out iron deficiency in the vast majority of patients. If we can't sort it out with the ferritin, then we need to get the hematologists involved and do a bone marrow. Dr. Costello said I'd talk about symptoms, and I wasn't going to, but I will a little bit. So in the history, when we're dealing with someone who has iron deficiency anemia, We'll ask them a little bit about diet, even though diet alone is an uncommon cause for iron deficiency. It may be contributing. Everyone is on aspirin and non-steroidal agents, and if they are, they can certainly be contributing to iron deficiency. A history of overt blood loss, so that if you are having bleeding, then obviously that is a concern and needs to be looked into, as well as blood donation. A family history of colon cancer always sort of gets our little spidey antennas up, because if you have a family history of colon cancer, you're more likely to have colon cancer. And if you're iron deficient, then it means that we probably need to be looking at your colon, particularly if you're more than 50 years old. And as well, if you have a history of a hematological problem, funny blood vessels, a bleeding disorder, or a family history of iron deficiency, or if you've been iron deficient before, all of those things are important in the history. In terms of physical exam, things that we tend to see in patients who are anemic, they tend to be pale, the blood pressure might be a little bit low, they may have a fast heart rate. If they're iron deficient, they may have spoon-shaped nails. We're going to look for a mass in the belly if we think they might have cancer, but we rarely are going to find a mass in the belly when we examine your belly in the clinic. There are some weird and wonderful things that gastroenterologists would think about. We're going to stick a finger up your bum in the clinic. You may not like that, but we're going to do that anyway. It's also useful to test the urine for blood. As Dr. Costello noted, we're all hipped up on the GI tract as being the source for blood loss, but 1% of people with iron deficiency anemia actually have a renal tract malignancy, so we need to think about that. Or, except we need to think about that for sure. So the reason that I'm here is that all postmenopausal women and all male patients with iron deficiency anemia should be considered for endoscopic evaluation. And which end you do first, the top end or the bottom end, it's difficult to say. I mean, there are some rules of thumb. Everyone should be screened for celiac disease, which is this gluten intolerance. This is an easy thing to do. It's just a blood test that your family doctor can order, and it's a very easy thing to look for. And celiac disease is not an uncommon reason for people to have iron deficiency. And this is just a reminder for doctors, is that if you look down from the top and you don't see any cancer and you don't see celiac disease, but you see some inflammation or an ulcer or something, it says maybe you should look on the bottom too, because they still might have colon cancer. So in terms of lower endoscopy, you've all heard about colonoscopies and the nasty preparation that you have to take before the colonoscopy, which is probably worse than the colonoscopy itself. We give you lots of drugs when we do this, and then you tell us all the stuff that you wouldn't tell anyone else. We don't record anything, and my memory is quite poor. But this allows us to look at the whole of your colon with a scope. It takes about 15 or 20 minutes total to do this. And if we see polyps and things, we can take them out. Hopefully we're not going to find a cancer, but if we do, we'll deal with it. The upper end, same thing, drugs and some spray in your throat, and test it around, have a look around. That only takes about 5 minutes to do, so that's a pretty easy thing. Easy for me to say it's a pretty easy thing, but it is a fairly easy thing to do. If we don't see anything on the top, and we don't see anything on the bottom, there's a whole other piece in the middle, which is your small bowel, which if you laid it out and got the total surface area of your small bowel, it's about the same as a football field. Now that's the total surface area because of all the convolutions and things. But there is a lot of area here, but fortunately it's very uncommon for disease in the small bowel, other than celiac disease, to be the cause of iron deficiency. And we have a variety of ways to get at the small bowel. Generally, we don't need to do that, and it's generally of low yield and doesn't add a lot. But we do have those kind of things available in patients where we don't see things on the top or the bottom. This is a horrible slide that you can't read, and neither can I even from here. I think what it does is highlights the fact that when we're dealing with premenopausal women who are iron deficient, we're thinking much differently than we are with men and postmenopausal women, simply because regular menstrual losses are more than enough to make you iron deficient. The other thing that this slide highlights is the fact that once you've treated iron deficiency, you don't just forget it at that point. You stop the iron, you wait 2 or 3 months, and then you check the blood tests again, because if the iron levels have dropped or the hemoglobin has dropped again, then you may need to go back to the drawing board in terms of looking for a cause. So special considerations, premenopausal women, you know, the combination of menstrual losses, pregnancy, breastfeeding, dietary deficiency can all predispose to iron deficiency. It's useful to look for celiac disease in that situation. It's only a blood test. It's not very expensive. Malignant tumors are extremely uncommon in this age group, so we're not that concerned about it, unless people have a lot of gut grief, in which case we'll look down in the stomach. If they have lower bowel symptoms, then maybe they should have the lower bowel looked at, particularly if there's a strong family history of colon cancer or if there's persistent iron deficiency.